It's a pleasure welcoming everyone here on this webinar under the title of Vaccine and Testing Challenges. As everybody know, when this pandemic hit us, we had no idea what we were facing, where we were going, where we were coming from. But one thing came as a result of this integration, I should say, is leading research institution, hospital, pharmaceutical company, um, basically all the biomedical enterprise that we have in this country came together in an attempt to join force to find a solution that is so needed for this country and for the rest of the world with no exception. Um, and as I said many times, in any crisis, you need to look at it from a brighter perspective and to see all the segments of the biomedical industry, whether academia and a hospital, as well as a research institution coming together and working together for the same goal, to being able to develop novel strategies that are going to be able to ward off a pandemic like this, is to be underlined and to be commended to everybody who is working on this process. The name of the webinar is telling the challenges that we're facing for vaccine, for testing. You'll hear in the mouth of everybody, yes to test, not to test, what to test, as well as how we looked at the future in regard to the vaccine is of importance. And the panel today is going to address some, if not all, those concepts. Today we have with us Dr. Donald Chen, Dr. Lawrence De Lorenzo, Dr. Abe Chen, and my dear friend, Dr. Robert Rubin, who comes directly from Lovelace Research Institute. First speakers is Dr. Chen. Dr. Chen is the hospital epidemiologist, medical director, infection prevention at Westchester Medical Center. He's an assistant professor at New York Medical College. He's currently, as we said, a hospital epidemiologist, and he's been interested in hospital epidemiology regarding different infection, and especially this COVID-19. He completed his fellowship of infectious disease and research in parasitology at New York University. He's been tasked, and he is the PI of the Regeneron clinical trial that we have, a joint venture between Westchester and New York Medical College, in an attempt to find some drugs for COVID-19. Dr. Chen points out that the study's systematic approach remains still a status quo, executed in a methodological and precise manner, which is for us of importance, because all of a sudden we position ourselves, if anything, as being strong partners in developing strategy for large clinical trial. The title of this presentation is COVID-19 Testing Approaches and Implementation. Without further ado, please join me in welcoming Dr. Donald Chen.
Thank you, Dr. Amar. I appreciate the kind words, and I look forward to this seminar and presentation. I shall go ahead and share my screen with the slides. So I'm going to introduce this by talking more about the hospital strategy and approach to testing and implementation of testing for COVID. And then I'm sure a lot of great detail will come from Dr. De Lorenzo and Dr. Dans. So first of all, there can be challenges in testing, and some of the questions have already been alluded to. Whom to test, which test to use, what are the indications for testing, what are the limitations of the various tests for COVID-19? And then, as we found out in our journey earlier this year, many other factors external to the test itself and external to the patient really do come into play. These are things such as the regulatory environment, test availability, test performance, and then what's going on in the community or prevalence of infection as that affects testing. So a quick look at diagnostic testing. We often talk about tests and test performance in terms of sensitivity and specificity. So sensitivity and specificity are measures to look at the ability of the test to find true positives and to hopefully not get too many false negatives, to optimize true negatives and not have too many false positives. So the more sensitive a test is, and you can see the grid here, this is a 2x2 grid. Here is the condition. So this is whether the disease is present or not. And on the other axis, test outcome is whether the test is positive or not. So you can see in the green boxes, true positives and true negatives are what we want to optimize, and we would hope to have few of the red boxes of false positives or false negatives. In other words, the test is negative, the condition is positive, or the condition is negative, the patient doesn't have COVID, but the test comes out positive. So sensitivity is defined here as true positives divided by true positives plus false negatives. Higher sensitivity really means fewer false negatives. And specificity is more about fewer false positives. So the rate of true negatives divided by the sum of false positives and true negatives. So just keep that in mind as we go along in this. There are three types of commercially available tests for SARS-CoV-2, or the SARS coronavirus 2, which is the causative agent of COVID-19. First is the SARS-CoV-2 RNA PCR. Second, SARS-CoV-2 antigen test. And third is the SARS-CoV-2 antibody test, which may detect IgG and or IgM antibodies. The SARS-CoV-2 RNA PCR common specimen sources are nasopharyngeal swabs or oropharyngeal swabs. There can also be nasal washes, tracheal aspirate, saliva. There are other forms as well that can be used depending on each specific test platform and what it's been approved for. This detects viral nucleic acid, and generally speaking, this PCR test, as with many PCR tests, has high analytical specificity and sensitivity. By analytical, what I mean by that is when this test is validated on a known sample that either has or doesn't have the nucleic acid, how well it performs to that known control, so to speak. It's a different concept than overall or clinical specificity or sensitivity, where you might have false negatives, for example, for other reasons outside of the test itself per se. It might be the collection of the test or other factors in the patient. SARS-CoV RNA PCR is evidence of current infection. However, the nucleic acid may persist for weeks in the absence of viable virus, or in some sense, that's an unanswered question when we have patients where the test persists, is the virus viable or not. The SARS-CoV-2 antigen tests came out a little bit after the early PCR tests. I'm aware of one FDA-approved antigen test. Specimens that may be used include the nasopharyngeal swab and nasal swabs. This test detects a viral antigen, in this case, the nucleocapsid protein. It has high specificity but low sensitivity, or lower sensitivity, compared to the PCR test. So here there's a greater potential for false negatives. It could be evidence of current infection. However, in the face of a negative test, the test may need to be repeated by PCR, so to avoid those false negatives. So generally, I would say that this test is less useful. The advantage may be cost for certain institutions, but one runs a risk of false negatives, more false negatives with this test. And then there's the SARS-CoV-2 antibody test. This detects antibodies to the spike protein and or nucleocapsid protein. It's evidence of prior infection. Generally speaking, the antibody levels appear to increase at 1 week after infection and peak 3 to 4 weeks. The specificity and sensitivity vary by test platform. And one thing to caution with this antibody test is the potential of having a higher false positive rate in low prevalence settings. So the grid I showed you earlier looked at sensitivity and specificity, but to get from those two concepts, which are based on the test itself, to the actual predicted value, for example, positive predictive value, we must also integrate population prevalence into the calculations. So for example, if the prevalence of antibodies in the population is actually very low, let's say at 2% in this chart here, and we're using a test with a sensitivity of 90% and a specificity, in this case the specificity is what's more important for this grid here, of 95%, then a positive test has a predicted value of only 27%. So almost 3 in 4 positives will be false positives. If the population prevalence is 5%, then actually half of the positive tests will be false positives. So you can see here, the utility of a test varies based on the population prevalence as well as by the specificity. If we have a much higher specificity test, getting up to the high 90s, closer to 100, then the positive predictive value would be better across the range, but still limited at very low prevalence settings. Some of the testing limitations include, for the RNA-PCR test, adequacy of the sample collection. The body site of sampling may affect this as well, and the persistence of RNA, which may or may not be viable virus. The antigen test, again, limited sensitivity is I'd say the greatest concern from my perspective. And the antibody test, the sensitivity and specificity vary. So in addition to the limitations in a low prevalence setting for the positive predictive value, some of these tests even had their FDA authorization revoked because of poor performance. More on the clinical side, it's not clear how long antibodies persist or if antibodies correlate with protective immunity, though there is more and more data coming out on those two fronts. In terms of whom to test, the CDC indications are a great place to start. First, testing of individuals with signs or symptoms consistent with COVID-19. So a patient comes in who might have COVID-19, that certainly is an indication to test for that patient. Probably the most obvious indication. There are other indications as well. Testing of asymptomatic individuals with recent known or suspected exposure to SARS-CoV-2 to control transmission. On the public health side, if a patient is identified and confirmed to have COVID-19, public health would typically then go in the household and find those individuals who are most highly exposed and test them as well to find out if some of the household members might be harboring COVID-19 or the SARS-CoV-2 virus and therefore at risk for transmission to other people. And by that, one could identify more cases to appropriately isolate at home. Next up is testing asymptomatic individuals without known or suspected exposure to SARS-CoV-2 for early identification in special settings. These settings could be places where the impact of someone coming in with COVID or having COVID undetected have a much greater impact. One example would be hospitals. Some hospitals, including our hospital, are testing patients upon admission, even if they don't have symptoms of COVID, to identify potential asymptomatic or pre-symptomatic patients. Another would be the nursing homes, where nursing home staff and nursing home patients are tested serially on an ongoing basis for COVID because of the impact to that setting if someone were to have COVID-19 and transmit it. Testing to determine resolution of infection. This, in certain circumstances, is used to determine how long a person with COVID stays on precautions or isolation, and in other circumstances may determine when a person who has had COVID is cleared to return to work. And finally, public health surveillance for SARS-CoV-2. There's a very important question out there as to how many persons have been infected with COVID-2 so far. This data can come to some extent from the PCR test. The antibody test is where we have an ability to identify persons with recent COVID infection, even if they're no longer testing positive by the PCR. So which test to use? The PCR and the antigen test are really designed for current or recent infection, though the antigen test is less sensitive and the antibody is evidence for past infection, though As antibody levels start to increase days to a week after infection, one might detect antibodies in someone with current infection as well. Now, some of the external factors affecting implementation include the availability of the tests, regulation, test performance, and prevalence of infection. I'll now go on to discuss our own experience and how that affected our testing strategy and our ability to test. So it's not always a question of whether we to test or not to test based on our own volition. It's also based on what's feasible. Early in the outbreak, from February to early March in 2020, there were no commercial tests available for COVID-19. This is a regulatory limitation, and as I understand it, as CDC had declared COVID a public health emergency, they had the right and authority to control the testing for this, and that limited commercial laboratories from putting out their own commercial tests for COVID-19. When COVID-19 testing became clearly needed and the capacity wasn't necessarily there through the CDC and health departments, then the FDA allowed, under emergency use authorizations, a more rapid pipeline to get more commercial tests available and approved for use, as well as to allow individual hospital and other laboratories to validate their own tests and run it in approved status. But back in February, early March, testing, when it first became available, was only available through the CDC and later through select health departments, with approval though. So this is limited in number, and for a test to be performed, the health department had to be called and each case was discussed with them, and strict testing criteria had to be met. There had to be symptoms of COVID, such as respiratory symptoms and fever, and a known exposure risk, either an exposure to someone known to be COVID positive or travel to an affected country. Early on, that meant travel to China. Later on, it meant travel to other countries on the level 2 and level 3 CDC watch list. And in addition to that, the turnaround time was several days, maybe even 3 to 5 days in general, to get the results back when those tests were approved. So here we ran into some issues where patients appeared that they could have COVID, but the test couldn't be approved because patients did not have fever. And as we know now, COVID can present in a range of presentations and does not necessarily involve fever, and persons are likely infectious even without fever and potentially when asymptomatic. So mid to late March of 2020, based on the FDA emergency use authorization, our hospital was able to validate and roll out a lab test developed internally. And then in the later weeks of March, there's increased availability of the commercial tests, but still limited. But at least we no longer needed to go through the health department to test patients. We could decide on our own which patients we would like to test using our commercial or internal hospital lab tests. So we made decisions regarding which patients to prioritize for testing. This included patients with clinical suspicion for COVID. It also included asymptomatic screening, especially for patients going to congregate settings. So patients being admitted to areas of the hospital where they would be around other patients, such as in rehab or in behavioral health, were also tested before going there. In April, we saw increasing test availability, and we were able to expand our testing to screen all hospital admissions. As during April, we did find that patients would arrive to the hospital for reasons other than COVID-19, but they would also turn out to test positive for COVID-19. In May, a number of regulations came out from the state health department regarding testing. This included testing for COVID-19 before elective surgeries and elective procedures, testing of nursing home residents and staff on a regular basis for COVID-19, testing for hospital patients before transfer to a nursing home. This led to an increased demand for tests, as did increases in COVID activity in other states, which then led to a decrease in test availability and greater turnaround times for tests sent out to reference laboratories. So in response to that, we worked on optimizing our testing strategies. We had rapid tests with 2-hour turnaround times. We had send-out tests to reference labs, and we also had tests done in-house that were not as rapid. In face of these challenges, we developed and brought in other platforms to do more testing within the hospital itself so that we wouldn't be as reliant on send-out tests. And that helped increase our capacity as both sides work together, the send-out test for volume and then the in-house testing strategies for places and patients for whom we needed more rapid turnaround time. And just to show some of the data related to this, the main part of the slide shows the New York State COVID-19 tracker. The number of tests performed by day in this histogram is in blue is the number of total tests, and then yellow are the number of positive tests. So over the time period starting in early March through the end of June, you can see that in late March to early April, there were times when approximately 40% of the persons seeking testing tested positive, with all the measures in place, in particular in the community, but also in healthcare facilities. This number has been driven down, and the rate of positivity has been driven down. Now we're testing about 1% of all tests are positive. Within the hospital, we've seen similar trends, and in late March, we peaked at about 50% positive among all the tests being performed, and we're now down to 1% testing positive. And in the graph below that, you'll see the histogram lined up in the same axis of dates of the number of COVID positive patients in the hospital during this time frame. We peaked in early April at over 200, and the whole tail, you can't see the tail completely out to the current date, but we're down to the single digits now in terms of COVID positive patients in the hospital. Back to antibody testing, we did bring in antibody testing subsequent to bringing in the PCR testing. Again, mostly for evidence of recent or prior infection. We're careful to say that the data aren't fully available to determine if antibodies equate with protection from reinfection, though there's more and more data coming out. And as we offer the test to the community, we're careful to communicate that positive tests and negative testing, nothing is 100%. There can be false positives and false negatives. However, we did choose a platform based on a high analytic specificity around 99.5%. I also want to share here in the table data from the New York State antibody testing surveys looking at populations, various populations, and the percent testing positive. Westchester County was testing about 14% positive for the general population, and New York City about 20% positive. However, if you look at healthcare workers in those same locations, Westchester was testing about 7% positive, and New York City about 12% positive. We have similar data showing that healthcare workers are testing at a positivity rate to antibodies lower than the general population, which helps to validate that our procedures in the hospital, precautions, use of personal protective equipment really are effective in limiting the risk of transmission within the hospital, and that risk may be lower than in the communities when COVID-19 is prevalent. I'll stop there. I thank you for this opportunity to present, and I look forward to the subsequent presentations and discussion.
Thank you very much, Dr. Chen, for this enlightening presentation. Very much appreciated. A couple of questions from the audience. One of them is, can you come up with the number of cases that you encountered in the hospital, COVID-19 positive cases, between the peak of the activity until now? And a corollary, out of that 1% case that you have right now, do they turn into the pathology that we have seen during the 40–50% peak of activity, or is it the pathology that is a little bit milder, I should say?
Great. Thank you for those questions. So in terms of the first question, we peaked at over 200 cases. I don't have the data at hand as to how many cases total we had in the hospital. We saw a range. You can try to integrate that curve I showed, but that wouldn't give you the total number of cases. Certainly, we have the whole spectrum of patients who presented with severe enough symptoms to be hospitalized, but they're discharged in a number of days, a small, short number of days, and we have patients who we're here for a much longer period of time and we're very sick. In terms of the 1% testing positive right now, for the most part, most of these patients are patients who previously were known to be or tested positive. They're being readmitted for perhaps non-related reasons or perhaps some residual respiratory reasons, but are still testing positive. Or they're patients who were not known to be positive and they're being admitted for other reasons, trauma, for example, cardiac reasons, and they happen to test positive, so they very well may represent asymptomatic persons. Whether the pathology is less now than in prior days, I don't think we have the information to answer that. I think one thing that might be happening is that since we're seeing such a smaller number of cases, we're not seeing that tip of the iceberg of the patients who come in very severely ill. So part of this might be a numbers game, but the other part of it may be that, as seen in other parts of the country, if the age distribution is shifting and we're seeing more younger people being infected, they may be less likely to come in with more severe disease. So thank you for those questions.
Any reason why the Roche DNA test was not mentioned?
Why the Roche DNA test wasn't mentioned? I wasn't mentioning any tests by name, but certainly in the hospital, we use several different platforms. We have the Cepheid test for our rapid test. It's about a 45-minute turnaround time for when the sample is received in the lab. With the processing and other aspects, we say it's about a 2-hour turnaround time. We are using the Roche test, Cobas, in-house as well for the majority of our testing. Each run allows for testing approximately 90 samples, and we're running 3 runs per day. So we have capacity for about 270 tests per day. The turnaround time goes closer to 4 to 6 hours from the time of the sample reaching the machine.
Thank you very much, Dr. Chan. Very much appreciated. You and I interacted over this clinical trial and still ongoing, and I'm looking forward to many more interactions. Thank you very much.
Thank you, Dr. Marr.
Our next speaker is Dr. De Lorenzo. He's a medical intensive care unit director at Westchester Medical Center, and he's the professor of clinical medicine at New York Medical College. He is also a co-PI of this Regeneron trial. At the forefront, pulmonary medicine. He's been working at the forefront and in the trenches of this pandemic, which I would like to commend all the panelists this morning. He's worked at the Westchester Medical Center Health Network for the past 39 years. A record, probably, Larry. Very nicely done. And he's the director of the Medical Intensive Care Unit. He's the co-director of the Pulmonary Critical Care and Sleep Medicine at Westchester and the professor of clinical medicine. As I said, he's a PI of the clinical trial ongoing, and he's going to be talking today about testing of the critically 3rd or 3-level COVID patient in the intensive care unit. Without further ado, please join me in welcoming Dr. De Lorenzo.
Thank you, Dr. Amar. So this is testing of the critically ill COVID patient. And I understand that the audience is a bit diverse, ranging from students to faculty to professors and scientists. And so I'll apologize in advance if I use clinical terminology, which may not be completely familiar to everyone. What I thought I would do is just perhaps give you a taste of some of the issues that concerned us in the ICU as it related to this epidemic over the past 3 to 4 months for the hospitalized and ICU patients, and the clinical challenges that we faced. So our testing really were the tools that we use to take care of these patients. So clearly, COVID-19 is a major public health crisis. The infection is spread by airborne exposure and direct or indirect contact with surfaces. And so in an effort to limit the spread of disease, every aspect of the contact between the population at large and each other and or the healthcare system is dependent on the accurate identification of patients infected with the virus known as SARS-CoV-2. Ideally, these tests should be sensitive and specific. That is, is the test able to detect the abnormality correctly and to correctly identify it? So the whole issue of false negatives was something that we had to deal with. We saw a number of these tests in which the initial testing was negative, but became positive days or even in some cases weeks after the initial suspicion. And so if there was a high enough degree of suspicion, we kept testing. It's been estimated that approximately 3 days after the onset of signs and symptoms, there still may be a false negative rate of about 20%. And so that has to always be kept in mind. Some of the reasons for this may have to do with certainly testing too early in the process, perhaps the inadequate or incorrectly obtained specimen for the test, and perhaps even things like the viral load. So the tests that has been used as a PCR test in the early, it is much more helpful in the earlier phase of the course of the illness. And again, this should be noted, this is not a viral culture. Typically, this earlier phase, within the first 3 to 10 days after symptoms begin, will yield a result that we are content with. The specimen can be obtained from the nasopharyngeal area, the oropharyngeal area, tracheal aspirate, or even saliva. So the test is an RNA test, and the test detects a fragment of the viral RNA. Therefore, a positive test does not necessarily mean that that an infectious virus is present, and that's based on the fact that some evidence that viral culture may be negative after 10 to 14 days of illness when the viral RNA may still be detected, and perhaps even longer in immunocompromised patients. The serologic testing, which Dr. Chen went through very nicely, may be helpful later on in the course of the illness. Are the antibodies present? The normal response to the infection should be the production of these immunoglobulin antibodies. The antibodies usually are present within about 2 to 3 weeks or 2 to 4 weeks after the onset of symptoms. And it can be useful when positive to identify those who perhaps had infection but may not have tested positive on a previous RNA PCR. And so also may identify persons who might be a donor of convalescent plasma. So what do we worry about, and what did we worry about during this surge at the medical center, which occurred from approximately late March of this year through all of April and early May of 2020. We had to really go through a process of upscaling our medical intensive care unit from approximately an 11-bedded general MICU to, at our maximum, 80-plus ICU beds over a relatively brief period of time. Approximately about a 2 to 3 week period, we expanded very rapidly. So starting in the emergency department, we worried about, were patients going to be admitted to the hospital? What was the severity of illness? What were the signs and symptoms? Did they have to go to the floor or to the ICU? Would there be enough ICU beds available or personal protective equipment for the staff? Medications such as sedatives, pressor medications, analgesics, antibiotics, and a host of other medicines. Would these be available? How would we protect the staff and ourselves and non-COVID patients or perhaps even visitors or family, in terms of isolation from this airborne and respiratory mediated virus. We had a limited number of negative pressure isolation rooms and HEPA filters available. When it was time for the patient to leave the ICU and be downgraded, where would they go? To a step-down unit, to the floor? Again, we faced infection control issues, cohorting of patients on COVID wards. And even as far as hospital discharge was concerned, would they go home, to a nursing home facility, to a long-term acute care facility, or to a rehab center? And so this may have been important early on in the illness, when, as you may have recently read in the newspapers, there was concern about discharging patients to the various nursing homes, which ultimately, also developed a large number of cases of this disease. In terms of the ICU care, what we continue to worry and worried about even more had to do with really what was the elephant in the room. And the elephant in the room was really the respiratory failure that occurred in many of these patients. This respiratory failure is known as ARDS, or the acute respiratory distress syndrome, or acute lung injury. And this is really a flooding of the alveoli with inflammatory cells, proteinaceous fluids, resulting in profound hypoxia due to intrapulmonary shunting of blood. It's also known as non-cardiogenic pulmonary edema and is a leaky capillary syndrome. Again, it is a syndrome, so the acute respiratory distress syndrome has certain components. First of all, there must be an acute insult or precipitating event. The patients will usually have shortness of breath or even respiratory distress. There needs to be the presence of bilateral airspace disease seen on imaging, such as a chest X-ray or CAT scan of the chest. The pulmonary edema, which I mentioned is non-cardiogenic, cannot be due to heart failure. And the hypoxemia that occurs is poorly responsive to increasing amounts of supplemental oxygen. And again, the mechanism is by an intrapulmonary shunt. So the mortality of this condition in COVID lies somewhere on the low end between 40 and on the high end 90% mortality for these patients needing mechanical ventilation, depending upon which center's reports you're looking at. And this changed and varied over the number of months that we followed this. The respiratory failure, or ARDS, can be caused by the virus itself causing a pneumonia, but also other potential causes of pneumonia. As a referral center, we see many immunocompromised patients because of our quaternary care oncology service, transplant services, and liver disease patients. So there is a lot of concern about the cause of infections and pneumonia in this population at large of all kinds, whether they be routine or opportunistic. So some of the other types of pneumonias we would worry about in terms of viruses would be things like influenza, respiratory syncytial virus, metapneumovirus, cytomegalovirus, adenovirus, other coronaviruses. And some of the superimposed pneumonias that we might be seeing could be bacterial in origin, fungal, atypical, mycobacterial, and a host of other types of non-virus infections. There is something called which you may have heard about, the cytokine storm, which is based on a cytokine release syndrome, which causes an acute lung injury and ARDS. And so this is an intense release of inflammatory cytokine mediators, which cause ALI, ARDS, perhaps above and beyond the actual viral infection affecting the bronchial and alveolar cells. Patients can also have underlying cardiopulmonary disease, congestive heart failure, cardiogenic pulmonary edema, which is caused by an increase in hydrostatic pressure within the pulmonary capillaries and movement of fluid into the alveolar spaces. And there is really, we do not use this to define ARDS, but there certainly is no reason why a patient with underlying heart failure couldn't also develop acute lung injury or ARDS superimposed upon their underlying heart failure. And then, of course, with respect to other causes of respiratory failure, we would always be asking, did we miss something else? Did we miss, a pulmonary embolism? Did we miss pleural effusion or a pneumothorax? Or could the ARDS be due to an entirely different cause, perhaps trauma, pancreatitis, transfusion-related acute lung injury, and a host of other issues? So gas exchange abnormalities cause this profound respiratory failure and ARDS. And our basic and go-to test is the arterial blood gas, which gives us certain measurements of oxygenation, carbon dioxide, elimination, and the arterial pH. So these defects in oxygenation, ventilation, or both can be manifested by hypoxemia, hypercapnia, and respiratory acidosis, or combined hypoxemia and hypercapnia. How are they used? They allow us to adjust ventilator settings accordingly. We can also take advantage of some non-invasive monitoring using pulse oximetry and end-tidal CO2 as surrogates for oxygenation and carbon dioxide elimination when appropriate, in order to minimize arterial blood gas sampling and therefore staff exposure to the patient population. It can also be useful in decision-making with respect to the need for supplemental oxygen, non-invasive or invasive mechanical ventilation, and some of the other techniques like prone positioning, ventilation, salvage ventilatory modalities such as airway release pressure ventilation, inhaled nitric oxide use, and or even ECMO, which stands for extracorporeal membrane oxygenation. So we must never forget that while the main and most severe issue we dealt with in the ICU happened to be respiratory failure, other organ systems were certainly impacted and could be a problem. So, is there an underlying comorbid disease or organ system dysfunction preceding the illness or occurring during the ICU or hospital course? In terms of cardiac issues, we certainly could see heart failure and arrhythmias, hemodynamic instability. Was there a need for pressors such as norepinephrine, epinephrine, or vasopressin to maintain an adequate blood pressure and perfusing pressure? Could the patient have underlying myocarditis as a result of the COVID? Did the patient have underlying coronary artery disease with ischemic changes, which is so prevalent in our elderly population? Renal failure was not uncommon, and we saw quite a bit of acute kidney injury with renal failure requiring renal replacement therapies. And so we relied on things like the BUN, the creatinine, serum electrolytes, including bicarb, to monitor this renal disease. The liver was not uncommon. Liver function tests were not uncommonly elevated in this population, and some of those tests are listed in this slide. We know that this disease produced a significant defect in the hematologic and or coagulopathic systems of the body. And so it was not uncommon to see patients who perhaps after being so heavily sedated for prolonged periods of time, so-called induced coma, would come out of that sedation with central nervous system abnormalities or stroke. These problems were measured by using imaging such as CAT scan or perhaps MRI. On occasion, we would have to rule out other infections using cerebral spinal fluid analysis and even EEG to determine if there was evidence of encephalopathies. So the hypercoagulable state was something that we, during the course and progression of this disease and the knowledge obtained from other centers had to deal with. We saw patients with strokes, deep vein thrombosis and pulmonary embolism, as well as thrombosis of other organ systems and even extremities in the hospital. Some of the monitoring data that had to be dealt with included the complete blood count with measures of hemoglobin, hematocrit, platelet counts, differentials, and interestingly, a lot of these folks had lymphopenia, the SED rate, the measures of prothrombin time, partial thromboplastin time, the international normalized ratio, the D-dimer, and the fibrinogen levels were all taken into account. In terms of infectious diseases, sepsis and septic shock were very common, and we certainly had to rely on our infectious disease colleagues for help in this regard with cultures and other tests, particularly things like the procalcitonin, to perhaps point us in the direction of superimposed bacterial disease or not. Were antibiotics needed, and if so, which ones? Endocrine function, we certainly dealt with our share of diabetics, and since we put some of these folks on steroids, it played havoc with their serum glucoses. And so glycemic control, which is always important in dealing with critically ill patients, in order to reduce the likelihood of infection and augment their immune system, needed correction almost on an hourly basis. But we also tracked thyroid function and measures of relative adrenal insufficiency as measured by serum cortisol levels. Inflammatory markers, which may or may not have changed during the patient's course and been correlated with the so-called cytokine storm, included measures of the white blood cell count, SED rate, the C-reactive protein, ferritin levels, IL-6 levels, and when correlated with measures of gas exchange and oxygenation, the chest X-ray appearance, and even vital signs such as the blood pressure, would point us in the direction of becoming either more or sometimes less aggressive with certain therapies. So another tool that we relied on quite heavily was in the area of imaging, and certainly the chest X-ray, which is probably the simplest and most commonly performed imaging study for looking at patients with pneumonia, was used on a daily basis. We would rely on portable X-rays, certainly to look at things like placement of the endotracheal tube, whether there were pleural effusions, how severe and extensive was the extent of the airspace disease, whether there was atelectasis or pneumothorax present, and the ability of the bedside portable imaging technology allowed us to keep the patients isolated in their rooms, and only very rarely would we want the patients sent out of their room to the radiology department for a more definitive test, such as a CAT scan of the chest, head, or abdomen. But these were done when appropriate, and if the patient was stable enough, for transport to the radiology department. Another very useful imaging technique, which could be done at the bedside, was the use of certainly ultrasound of the chest, abdomen, or even extremities to look for things like DVT, pleural effusions, whether there were localized collections of fluid in the abdomen, the size of certain organs, And so we utilize this when possible and when appropriate. MRI scanning was available, but certainly not used on a very common basis. Patients would have to be out of the unit for a more prolonged period of time. And so they really needed to be more stable, and that the test would show us something which we could not ascertain on other types of imaging, such as CT scanning. And this was most useful in patients who perhaps had a very strong suspicion of a stroke or cerebrovascular accident, and it was just not possible to diagnose it using CT scanning of the head. So I guess our biggest challenge in terms of using all of this testing was really to put it all together. Again, what was the severity of illness? Was the patient stable or unstable? Was it a single organ or multi-organ system failure problem? We literally had hundreds of pieces of data to coordinate for each patient on a daily basis, and many times more frequently, even hourly. We had to think about minimizing exposure, people going into the room. Did we have enough PPEs? And again, as I mentioned a little while ago, about whether we could have the patient come out of the room. Moving patients through the system certainly will require COVID testing on more than one occasion. Certainly Dr. Chen made reference to this. But other considerations included things like, what is going to happen to the longer-term care patient, patients with chronic respiratory failure who have to be placed on chronic ventilatory support. We're now developing a small population of patients who, can't seem to be weaned from the mechanical ventilator and wind up getting tracheostomies for more prolonged nursing care and ventilatory assistance, and the need for supplemental chronic care such as renal replacement therapy with dialysis is really something that's been a problem. How can we plan to do what we've tried to do a little better the next time if there is another wave of disease or surge, which we certainly hope will not be the case? And this involves all planning at all levels and the need for data as it relates to the epidemiology, the prevalence of disease, new case finding, and hospitalization rates. And so that concludes my discussion of the testing that we found necessary in the intensive care unit. And I suspect that perhaps Dr. Don will have a little bit more to say from this from an infectious disease perspective, and appreciate the comments that Dr. Chen provided in his previous discussion. Thank you very much.
Thank you very much, Dr. De Lorenzo. Two questions. You mentioned corticosteroids. Any success with remdesivir, and would you consider any combination of therapy? That's the first question. And the second question is, with this very intense pathology profiling of patients, what kind of sequela have you seen and with patients that have suffered and survived the COVID-19, and most importantly, with any sequela that patient will keep for the rest of their life, basically?
Yeah, excellent questions, Dr. Amar. So with respect to some of the therapies that have been advocated for this patient population, literally the therapies were changing on almost a weekly or every other week basis. And so early on in the disease process, we didn't have access to medications like remdesivir, which subsequently became more available. In terms of steroid medications, we had a population of patients for whom corticosteroids were given in a variety of doses, not knowing what was the correct dose to be given for this intense inflammatory process. We also gave certain IL-6 inhibitors, as you had mentioned. We were part of a randomized double-blind controlled study using sarilumab at the medical center. And when we found patients who were appropriate candidates for enrollment in that study, they did receive that medication. But tocilizumab, which was another IL-6 inhibitor, was used probably on an even more common basis. And we're not sure really where the results at our institution fall out yet, but there have been some reports coming from institutions throughout the country and the world, as you may know, that corticosteroids such as dexamethasone, which recently came out in the last 2 weeks as being useful, again, may be something that we can focus on a little bit more as we see more of these patients in the future. And the second part of your question again, Dr. Amar, was
concerned about
the chronic nature of these folks when they sort of get over their ICU stay. And this is, again, a difficult problem. We have not, at this point, seen follow-up about patients, but listening to other web pods from other institutions, there is a population of patients growing who have some more chronic problems with musculoskeletal disorders, thinking disorders, and respiratory disorders, of course. We don't know how long this will last. We do have a population of patients within the hospital who have transitioned from the ICU to step-down areas and are still on ventilators, unfortunately. And we'll be monitoring those patients for either discharge, if appropriate, to nursing facilities or LTACs.
Thank you very much, Dr. De Lorenzo. Very much appreciated the insight on this very devastating pandemic. Thank you very much. Our next speaker is Dr. Abhay Dan. Dr. Dan is the Director of Transplant Infectious Disease at Westchester Medical Center, and he's an Associate Professor of Medicine at New York Medical College. He's currently serving for a certain time. He did his transplant and infectious disease and antibiotic stewardship at Westchester Medical Center. He completed his fellowship in infectious disease in a place that is very dear to me, Tufts Medical Center in Boston. And he has been an attending physician in infectious disease at Westchester, similar to many, many other people in the trenches, in the middle of the crossfire during this major war that we mounted against this little virus, I should say. Recently, he was the primary investigator at the Westchester Medical Center to study the role of convalescent plasma in treatment of COVID-19. And the title of his presentation is Interpretation and Clinical Implication of COVID-19 Testing. Without further ado, please, Dr. Dan.
Well, good afternoon, everybody. And thank you, Dr. Amar, for inviting me for this talk. This has been quite an experience. So I think while we were taking care of all these patients, it was truly a multidisciplinary approach. And those of you who have not seen me in the last 3 months with my new look, that is white hair. I've been reminded multiple times that I do have developed white hair. And in March, I had no white hair. So this thing has taken a toll on all of us. Just for disclosures, I have nothing relevant to this talk. One disclosure that is very important, all the information that's coming in is changing. So whatever I might tell you today is to the best of the knowledge that is available, and it can change by later today or by tomorrow. So a lot of information is coming in. We're learning a lot about the basic mechanisms of the disease and the treatment, and how are we going to use all that information to help prevent the infection and treat our patients appropriately. So just to start, where is the incubation, what happens with the infection, and how does the infection begin? This is based on two studies, both out of China, one out of Wuhan province and other out of the Wuhan province. And this basically tells you in this slide is what is the incubation period. So right from the exposure to the onset of symptom, the mean incubation period is anywhere around 5 to 7 days. Of course, it can vary from various people, but the median incubation and the mean incubation is somewhere around 5 days. So this sets up to the temporal considerations for the diagnosis. So this here you see is the onset of the symptoms. So before the onset of the symptoms, any detection of the virus or the diagnostic tests that lead to the making the diagnosis are most likely going to be negative. So these are the various PCRs that we've been talked about. PCR is basically detecting the virus. Antibody detection is the response to the virus. You can look for the virus in various places. This is mainly a respiratory virus, so the main place that you look for would be in the respiratory tract, starting from the nasopharynx to the oral cavity to the bronchoalveolar, that is lower down in the lungs in patients who do develop pneumonia and respiratory failure. Besides being a respiratory virus, it is a multisystemic virus. You can see virus in other places beside the respiratory tract, and one place to detect would be in the stool as well. So you see in this cartoon is before the symptom onset, detection of either the PCR or the antibody is going to be very less likely. First thing that develops after the onset of the symptom is the PCRs, and PCRs can be detected pretty much from all the sites in the respiratory tract and in the stool. Detection goes down from the upper respiratory tract and from the lower respiratory tract. It can persist for a longer time, and even in the stool, you can have persistence. Somewhere around the 10-day mark, you can see the antibody detection. And with the onset of the antibody detection, the PCR can persist for a while, for up to 2 to 4 weeks, and then PCR becomes negative and the antibodies remain positive. So these are the two modalities of the test. One is the viral nucleic acid that is being looked by the RT-PCR, that is looking for a current infection. The issues are false negatives that have been discussed before. The major implication of the false negative test is basically from improper sampling, and if multiple samples are repeated or a different modality is used, the test can actually be positive in a patient who presents with all the signs and symptoms suggestive of COVID-19. Then you have the serological response, and the serological response can be both from the blood, plasma, or the serum, and that indicates an exposure to a recent infection or a past infection. And this response happens few days after the onset of the symptoms. You can have false negatives, which vary from the platform, and you can have false positive due to cross-reactivity. Just a word of caution, you guys might have known it is a type of coronavirus. There are a lot of other coronaviruses that are around that cause human infection, and other coronaviruses that are not associated with human infection. Now, looking at the viral load, now what we're doing is a SARS-CoV-2 PCR in which you're looking at the viral load. Now, what this slide tells you is that onset of the viremia, detection of the viral load, and then the persistence of the viral load. So around 10 days or before, you will see the onset that you will see in the oral cavity in the saliva and in the endotracheal cavity. The caveat being in the endotracheal cavity, the symptoms you can see a higher viral load and it can persist for a longer time. So it varies from where the sample is collected. That will help decide, is the sample going to be positive and how long the sample is going to remain positive. But as a rule, viral load is highest during the first week after the onset of the symptoms. So here you see, and further away from the symptoms you go, the viral load goes down and the persistence of viral load is maintained. Also, the viral load varies by the sample time and the disease state. So this is kind of the same slide that is comparing the nasal swabs to the throat swabs to sputum, blood, and urine. And you see very low level of detection in the blood and in the urine, but you do see persistence and detection in the nasal swab, throat swab, and sputums. And same thing, sputum viral load by the disease. People who have early disease and do not progress versus people who have recovered, or people who have a clinical cure, you can see the mean viral load is very different. So when we are interpreting all these studies and we are looking at that stuff, it's important to know what type of viral samples were studied, what time were they collected, what was the modality that was used to test. So when you're comparing one study to another study, it is important to know where the swabs might have been taken and what modality was used to test these samples. So again, this slide tells you about how it is different. So see, the viral detection in the stool can persist in patients who've had a negative pharyngeal or a sputum viral test, but the fecal samples still persist. Does not mean the person is actively infected, but what you do find is persistent shedding in the stool that is noted in majority of these patients when you compare them to the respiratory samples. So what are the implications of the antigen testing? So I'm going to go step by step. So first you start with a symptomatic patient. So you have a patient with symptom, you're trying to make a diagnosis. Now, when we started early in the process, there was a transition phase where there were a lot of community onset viral infections going on at the same time, which led way to the COVID infection. And as we go forward, as the season changes again, we are going to see other respiratory viral infections which are seasonal, which might confound making the diagnosis. So if you have a person who's coming with UR-like symptoms, that would be fever, cough, shortness of breath, or sore throat, it's important to know, one, is it a viral infection, and which is the virus that might be causing the infection. So this antigen test helps distinguish one viral syndrome from infection that is being caused by the coronavirus, SARS-CoV-2. So the clinical implication in symptomatic patients is we have a decision to make for patients who have a positive test. Do we need to hospitalize these patients? That depends on the severity of the disease. So we did come up with a treatment algorithm or a management algorithm to decide patients who were symptomatic, which patients need to be hospitalized, and of those patients, which patients need to be in a monitored intensive care setting versus patients being on the floors. Then we had a treatment modality. When we started, there was pretty much no treatment modalities. Everything was being done in the best case scenario of the information that was available. Treatment decisions including picking an antiviral agent, whatever antiviral agent we thought was the best antiviral agent, the agent at that time that included hydroxychloroquine, and at the end of the disease, moving on to remdesivir. So a decision has to be made for, does the patient require an antiviral agent? Then you move on to other immunomodulatory agents that would require steroids, which steroid to pick, what dosage to pick, what duration of steroids to give. Also to management of end organ involvement that was through the cytokine storm using IL-6 inhibitors. So those decisions are also based on patients who have an antigen test that is positive. It's not just patients are presenting with a clinical syndrome, they have to be positive for SARS-CoV-2. The other things we have to decide for patients who are symptomatic was, do we need to do other diagnostic procedures? Do we need to do additional radiological procedures? Do we need to do additional testing procedures? Do we need to do a CT scan or a chest X-ray to try and make a differential diagnosis? As Dr. DiLorenzo mentioned, a lot of symptomatic patients can have similar presentations. This being not just a respiratory virus, it causes multisystemic disease. People can have inflammation of not only lungs, they can have inflammation of the liver, they can have an inflammation of the muscles, that can be the heart muscles or the skeletal muscles, inflammation of the blood vessels. So a lot of things can present the same, and antigen testing in that scenario helps distinguish a bacterial pneumonia from a viral pneumonia from a SARS-CoV-2 pneumonia. Same thing, it can help distinguish somebody having a myocardial infarction or a myocarditis that was because of SARS-CoV-2, or a pulmonary embolus or a deep venous thrombosis that was associated with the infection. Also in symptomatic patients, important to make a diagnosis, because then you can try and find out what is the risk of spread. A person who is symptomatic and is exposed to general population is at risk of spreading the virus further. So it's important to test the symptomatic infections, one, to make the diagnosis, to make sure you are treating people appropriately using the right modality. Also, you are looking at all the modalities to prevent the spread of the infection. Then we have symptomatic patients who are in the hospital. So we have clinical decisions to make. Some of these decisions I talked about already. Basically, what are the modalities that you want to use to change the disease spectrum and disease outcome. Also, it's important to have infection control and prevention implications. Where do the patients go? What kind of room do the patients go in? What kind of other masks and precautions that you need to do to make sure the healthcare workers remain the same and do not take the infection from one patient to the other patient. Then you have asymptomatic persons. So clearly there's a role of antigen testing to try and find out people who are asymptomatic but are carriers of the infection. These people don't need to be hospitalized. They do not require any treatment, but it is important because these people can actually spread the virus. These people tend to be usually younger, usually immunocompetent. They tend not to have very mild symptoms or no symptoms at all, but they are at risk of spreading the infection. So another important patient population or a person population to study for antigen testing would be these asymptomatic persons, with the main goal to try and prevent spread of infection among the general population. Then you have people with resolved symptoms. How does the antigen testing help in people who have resolved, the symptoms have resolved? Now, this might be important in a subset of people who are at high risk of developing either a complication from the infection or are going on to develop certain high risk procedures. Now, what would be the high risk procedures? So during the disease process, the cancer did not go away, the transplant did not go away, the autoimmune disorders did not go away. But what went away was the treatment of these patients, because the hospital was all flooded with patients who were seriously ill because of COVID-19. Now that we are going on, there would be a subset of patients who had infection, the symptoms have resolved, but now they require procedures that are going to make them immunocompromised. So an antigen testing can help decide what is the risk of reactivation or progression of these people who you're going to make actively immunocompromised. This would require people who are going to be treated with chemotherapy for various cancers, people who will undergo solid organ or bone marrow transplantation, or people who have autoimmune disorders that require various other immunomodulatory diseases. So what the antigen testing helps in this scenario is a serial antigen testing that becomes negative at a certain point is a little reassuring that these patients, regardless of whatever therapies you're going to give them that are going to make them immunocompromised, their risk of reactivation because of the virus would be low. So that is an important clinical decision making in certain high-risk patients where antigen testing is helpful. So moving on to the next modality, from antigen testing to the viral antibody response. Again, all antibody is not the same. So what we're looking at is a viral infection that produces antibodies that are of different isotypes, of varying target and various specificity. High affinity antibodies are generated with maturation, with somatic rearrangements and hypermutation. And then you have non-neutralizing antibodies that recognize viral epitopes. Then you have neutralizing antibodies that look at certain specific viral epitope, and they are very helpful in controlling the infection. So here you look at IgM antibodies followed by IgG antibodies. And these are the functional activity of all the immune globulin isotopes leading to neutralization, opsonization, sensitization of the natural killer cell killing, sensitization of the mast cells, and complement activation. IgM basically helps with, that is an early antibody response, would help with complement activation, as well as the, sensitization of the mast cells. But the main use of IgG would be in opsonization and neutralization of the antibody. So IgG is the response, is the one that we're looking for that will help prevent the symptoms as well as prevent the spread of infection from a localized infection to a generalized infection. So these are the various antibody tests. This might not be complete, but this is just an overview of the type of assays that are available. When do they become positive? What is their sensitivity and specificity? And what does the antibody test us? Starting with the rapid diagnostic test. The tests are available in 10 to 30 minutes. You see the sensitivity, it is variable and it can be specific. But what it is looking for is just antiviral antibody. It's a qualitative test, does not tell you anything else, does not tell you the antibody titer, does not tell you the neutralizing antibody. So the only thing it is helpful is just for epidemiological purposes to see, was this person that we're testing ever exposed to SARS-CoV-2? The second modality of test is the ELISA test. The testing varies anywhere from 2 to 5 hours to get the result back. Sensitivity, very early in the disease process, is low. As you go further away from the symptoms, the sensitivity becomes high, and this high sensitivity is also associated with very high specificity. It can tell you both the presence and the level of the antiviral antibodies. It will be a quantitative test. Not only you can just look for the detection of antibody, you can also look at the neutralizing activity of the virus, of these antibodies. Neutralization assays, these are not available commercially for the most part. These take few days to cut back. Sensitivity is 90%. We do not know the specificity as of yet based on the clinical studies, but clearly it's a neutralization assay, so we would expect the sensitivity and specificity to be pretty high. It is looking for the presence of antibodies that can inhibit the virus growth. You can miss the antibodies to viral proteins that are not involved in the replications. You're looking at certain targets only. But again, it is helpful at least to tell you, does these antibody might have a protective effect against the virus. Then you have the luminescent assays, which are again rapid. You get it back in 1 to 2 hours. Sensitivity is low very early in the disease process, but once you go around 14 days of symptoms, the sensitivity goes up and the specificity is decently high. It also looks for the presence and the level of antiviral antibodies. It can also tell us about the neutralizing activity of these viral infections. So not all antibody detection tests are the same. Antibody, they can vary from where the test is done, and it gives different amount of information when these tests are done. Also looking at the variability in the neutralizing antibodies. Are all antibody responses the same? The answer is no. So this is the study looking at the symptoms. Patients, 175 patients who had developed mild symptoms. And you can look that when you look at these titers, there's a huge amount of variability in the titer measurement. 6% of the patients had undetectable level antibody. And then as you go, you had a subset of people who had a very low level of detection. And then you had a subset of patients who had a very high level of detection. So just because you have been exposed to SARS-CoV-2, and also depending on what modality of testing you are using, there is going to be a huge amount of variability in the neutralizing antibody. And that is also a confounding factor when you analyze these studies and you're looking at the treatment modalities and you're looking at the efficacy of the various vaccines and other protective modalities that we might be looking for. Again, you're looking at the disease process further away from the symptoms. That is where you start seeing the antibody levels that are high. So you get a consistent response around 14 days after the onset of symptoms, where the antibody, including the neutralizing antibody levels, might be high. But do they persist? So what we're looking at is the antibody response that can vary from the severity of the disease. It can vary from different genetic backgrounds of the patients. It can vary from various comorbidities. It can vary from the age of the patients and if they had a history of infection and how severe was that infection. So different studies show different things. Certain studies show that the older and middle-aged patients had a higher plasma neutralizing antibody. The other studies showed that the severe disease was associated with slightly higher neutralizing antibody, while the other studies showed no difference between mild moderate disease and the severe disease. So this still remains an inexact science, and we're learning more about this antibody response, the durability of the antibody response, and the protection that is offered by this antibody response. So this brings us to the antibodies in the treatment of COVID-19. Natural immunity that is there after the initial response. What is unknown right now is the viral response. Is it protective? Whatever we detect, is it protective? And how long does the protection last? Various studies that are coming along, they say that antibodies, whatever we are detecting, tend to wane after a period of 2 to 3 months. Does that mean the immunity goes away? It is still unclear. Vaccination. Vaccination would be for prevention. And again, depending on what targets were used to make the vaccine, the durability of the response and the type of immune response that is generated by different vaccines would be very different. What is available right now? What is available is passive antibody therapy. And passive antibody therapy can be used both for prevention in very high-risk patients and in treatment of the infection. So what is available is the convalescent plasma. In next few slides, I'm going to talk a little bit about that. And convalescent plasma would have non-quantifiable, different varieties of antibodies. It will be very unclear if they'll be neutralizing, whether they be protective or not. But what we know is we're giving the patients a lot of different type of antibodies. This is followed by an hyperimmune globulin, in which you are giving patients immune globulin, which has been spiked with SARS-CoV specific antibodies. And this is followed by monoclonal antibody. These monoclonal antibodies would be synthetic antibodies, which are against a certain target. What are the limitations of these passive antibodies? That they are useful only for a certain time. The half-life of the antibodies in the plasma, in the hyperimmune globulin, and the monoclonal antibodies would be certain weeks to months. So after a certain point, that antibody and the protection that is offered by those antibodies will wane. So it does help us buy time while we look for better cures and the vaccination to come forth. These would be one of the modalities that will help us take care of some of the patients, including very high risk patients. So what is the history of microorganisms for which antibodies have been used in human diseases? This is a whole exhaustive list where it has been used. Where do we use it right now? We use it in certain patients with pertussis, in patients with tetanus. We do use it in hepatitis B after exposure in certain patients. We have used it in respiratory syncytial virus patients, especially patients who are very young patients, the monoclonal antibodies, and certain exposures to varicella viruses. So there is a history of where antibodies have been used for treatment of certain infectious diseases. And this is a cartoon that tells you how do these antibodies work. So they work through various mechanisms. It can go from opsonization to activation of the complement, neutralization, direct neutralization of the virus or the toxins that are being produced by the virus. Also, they help with the antibody-dependent cell cytotoxicity. They can have direct antimicrobial activity. They can dull the immune response, the inflammatory response. So a lot of symptoms that are not only just from the virus, but from the immune response to the virus that can be mitigated. So there are a whole host of responses that are mediated by the antibody against the virus or other infectious agents. This brings us to the COVID-19 convalescent plasma therapy. So you have a patient who had developed COVID-19 and has recovered. Now the body is full of antibodies. So these antibodies are harvested, they are collected through a blood draw, with the presumption that the plasma is going to contain a lot of antibodies, including virus neutralizing antibodies. Through the serum, these are the antibodies that are given to high-risk patients for prophylaxis, so they do not develop the disease, or for people who have actually developed the disease for treatment of infection, especially in the setting where treatment modalities are very, very limited. So this is the workflow that we use. We have a patient with a history of COVID-19. We made a diagnosis using the antigen. We have a positive test. More than 14 days have resolved. The symptoms have resolved for more than 14 days. Again, it's important because this is where you're going to see maximum antibody response. Plus, antigen would go down. So the risk of transmission of the virus would go down, even though the detection of virus in the blood is very, very low. So there's a pre-donation screening, which is done by the clinic provider to look for no symptoms, time away from the symptoms. Then the blood is collected to look for the antibodies. Very early in the infection, some of these conditions were waived. All we really needed to know were the symptoms resolved and were symptoms more than 14 days. So you look at patient with a negative swab, so the antigen is negative. You look at the antibody response. You're looking for a neutralization titer. Again, neutralization titer was not available very early in the disease process. The donor is contacted, donor is referred to the blood center. You look for all the other infections. They're screened for all the other infections that can be transmitted through a blood donation. Make sure they are negative. That is where the blood is collected and it's converted into plasma, which is frozen, and that is known as fresh frozen plasma. All these were done under investigation, either approval through the FDA or through a larger clinical trial. And then ABO-compatible plasma was given to the patients who were admitted to the hospital with various stages of the infection. So that is where we used antibody tested for treatment. Now moving on to serology and epidemiology, Dr. Chen talked about it a little bit. Again, specificity when you're looking for the using antibody for epidemiology purposes can vary. Even though so if you look at tests with 96% specificity, 90% sensitivity, it is important to know what is the general population that has been infected. So if only 5% of the population is infected, only 54% of the positive results would indicate a true infection. So these tests are, you have to know the background of where you're utilizing these tests for epidemiological purposes to find the relevance that is associated with the antibody test. So moving on to serology and the clinical implications, what does the presence of an antibody tell us? We're looking at the durability and the persistence of natural and passive immunity. So hopefully if we do develop an assay that is looking for neutralizing antibody, in patients who have received passive antibody, it can help us decide what is the durability and persistence and how long does that protective response last. Do these people who are still at high risk of developing infection in the setting of virus being prevalent in the community, do they require a second dose of, say, plasma or a second dose of monoclonal antibody while we're waiting for the vaccine to develop? Also, it'll help decide the candidacy for vaccine. Once the vaccine is developed and the vaccination is available, there might be a limited amount of vaccination that is available. So presence or absence of the antibody might help decide which patients need to be vaccinated first. Maybe patients who do not have a detectable antibody could be the patients who would be screened, including high-risk patients, would be the first patients to get the first wave of vaccination, followed by subsequent patients. Also, antibody, as I mentioned, help decide donation for the convalescent plasma. Presence of the antibody, especially the neutralizing antibody, makes them candidate for donation of the convalescent plasma. Also important would be patients who are at high risk, would be high risk healthcare workers and people with ongoing exposures. Also, it is very important for us to decide patients who would be that we are going to transplant, because we would be making these patients more immunocompromised. So presence of an antibody might help that they are either safe. Also, if the antibody is not there, we could use monoclonal antibody or convalescent plasma to help prevent infection in these high-risk patients. What are the other societal implications of serology? Now, this would be a little controversial, so I just put a long list that where it is helpful. This is not an endorsement of one way or the other, and we're still far away from learning a lot of these things, but it would be important when the travel is there to try and see which patients might be at lower risk of contacting the disease or spreading the disease. It would be helpful for return to work, deciding public vaccination, which patients to prioritize for vaccination. At some point, the daycares and the schools and the colleges are going to open. So antibody might be helpful, especially in the workers, to see, are they safe to go into the workspace? Also important in inmates, because what are the high-risk situations where there are a lot of people crowded together in small places? So the risk would be in people who in the jails who are inmates, in nursing home, in shelters. These would be high-risk patients. And so screening would be important to see, can these people be maintained in these enclosed spaces or not? Elections would be coming. Would it be important to try and see people who would be manning these election stations? Are they at risk? Are patients a general population? Is it safer to go on and vote in the elections, in the local elections and in the national elections? So this is just an overview of utilization of antigens and antibodies. What are the clinical implications? What are the societal implications? Thank you.
Thank you very much, Dr. Dant, for this very insightful presentation. You mentioned few interesting concepts that I've also been struggling with. The big bag of asymptomatic but still contagious patient versus neutralizing and non-neutralizing antibody. Are these asymptomatic people completely genetically immune to the virus? Or are we talking about people that are recurring of an infection and have enough neutralizing antibody to ward off the further of infection? And my last question is related to the aspect of non-neutralizing antibody that we see circulating in many patients. Is the virus evading the classic immune control that we have in immunology?
So great question. So let me just start with the last one. I think the neutralizing antibody is, we call it neutralizing because we have an assay looking for neutralization. So just because it is neutralizing the virus in the lab does not mean it's going to, so the non-neutralizing antibodies might still be neutralizing or preventing the infection in various other ways. So neutralizing antibody is limited by the assay that we are using. So this is where the response to infection is unknown, that once the virals respond. So I think let's just take a step back. This is what happens in a lot of viruses that we know. Certain viruses develop different antibody response, and not all, so certain viruses like cytomegalovirus or herpes virus, we do get an antibody response, but that is not necessarily a protective antibody response. Now compare that to coronaviruses. We know coronaviruses, the other routine human respiratory coronaviruses, once we are exposed to them, especially in children, they do maintain immunity over a longer period of time. So since the closest thing that we see is SARS-CoV-1 or coronaviruses, a normal exposure to the antibody, maybe it neutralizing or non-neutralizing, would offer some sort of protection. So the first question for asymptomatic, I think that needs to be answered. We have really no answer. People remain asymptomatic. Is it because they protect the virus, or do they have some genetic or age-related susceptibility that they're not really, the infection is not progressing in those patients? Those answers are still not there, and I think it would be silly of me to try and give an answer, but those are studies that are ongoing, and hopefully we can be part of those studies to try and answer that precise question of what are the factors that are associated with asymptomatic patients, patients who develop severe disease, people who develop mild disease, and it'll help us take care of these patients in what I hope is not the second wave of infection that might come. So a lot of questions need to be answered.
Thank you very much, Dr. Dunn, for this interesting presentation. And we move to our last speaker, Dr. Robert Rubin. He's the president and CEO of Lovelace Biomedical Research Institute, located in Albuquerque, New Mexico. The Lovelace Biomedical Research Institute made the news many times in regard to their capability of developing vaccine to major virus that we had throughout history. He has been a very entrepreneurial into changing and transforming a platform of research into 12,000 jobs, $120 million in new revenue, moved the institute from a client base of 6 to 250. He is here to give us the entrepreneurial aspect, but most importantly to give us insight as to what does it take in regard to drug development during a time of crisis when this race is just unbelievable, with the needed preclinical approach to emergency vaccine and antiviral drug development, given their track record of developing vaccine for several viruses that we had. Without further ado, please welcome Dr. Robert Rubin.
Thank you, Dr. Meyer. My name is Bob Rubin. I'm president and CEO of the Lovelace Biomedical Research Institute here in New Mexico. And what I'd like to do today is to give you a sort of a state of the art is in terms of what we're doing here and elsewhere to combat this terrible pandemic. we'll be looking at talking about the preclinical approaches to getting a vaccine or an antiviral out to the public. And I'd hope to give you some information on why it takes so long, what are the stumbling blocks that we may experience along the way, and get you some feel for how we get a drug or a vaccine through the FDA process. My organization is involved in at least 20 individual projects with biotech and pharma and government clients to advance vaccines or antivirals as fast as we can. And as you'll see, the FDA is giving us some opportunity to take some shortcuts to meet this really serious pandemic. So without further ado, I'm going to try to move along here. Let me just take a moment and get this out of the way. Okay, so there's my title. So this cartoon, which is from the latest Scientific American, gives you a little bit of a feel for the what it is we're trying to do here. In the cartoon, you can see that the virus has a protruding stem or a spike, and attached to that, we see that the host cell has a protease, and the receptor is called an ACE2 receptor on the host cell. And we are attacking almost all aspects of this process right here of viral binding to a host cell. So we find that we are trying to produce antibodies against the stem or spike protein. We have in the process of elucidating the biomolecular structure of this spike protein, and we are developing ways to inhibit its binding to the receptor, the ACE2 receptor. We have already elucidated the structure of the ACE2 receptor, and we are testing ways to competitively inhibit the virus binding to that receptor. We're also looking at ways using small molecules that are being discovered as we speak to inhibit this protease. This protease, which is on the surface of the host cell, has to cleave part of the spike protein for the virus to have its membrane fuse with the membrane of the host cell. And so if you can inhibit this protease, you will inhibit transmission of the disease. And there are at least 2 drugs that are in preclinical testing right now that inhibit this protease here. We're also, as I mentioned, developing antibodies directly against the spike protein. And we are, in fact, developing epitopes of the spike protein itself to use as antigens to induce immunity. Furthermore, the RNA sequence of the SARS-CoV-2 virus codes for proteins that must be chopped up, cleaved in the process of viral replication inside the cell once they've entered the cell. And there is a cysteine protease there that has been studied recently and for SARS-CoV-2. And we have identified a couple of inhibitors of that protease as well that are being investigated at preclinical level to once again inhibit the replication of the virus. Once the virus RNA is inside the cell and has taken over the cellular machinery, there is an RNA polymerase that is associated with the replication of that RNA from the virus. And it turns out that the drug that's getting a lot of attention right now, remdesivir, inhibits that RNA polymerase because it is itself an abnormal nucleotide. And once it is added to the chain during chain elongation of the nucleic acid synthesis process, the RNA polymerase ceases function. It no longer can add an extra nucleotide, and you stop replication there. Lastly, we see that the binding of the spike protein to the ACE2 inhibitor may itself induce inflammation, may induce blood pressure changes. And there are a lot of efforts to try to affect this process. As I'll mention, there's reason to believe that levels of androgen affect the number of ACE2 receptors on the surface of cells, and there are efforts to try to reduce the numbers of ACE2 receptors on the surface of host cells. And then you see in this cartoon that the host cell is shown as a lung cell, but we know that ACE2 inhibitors are present on many cell types, and there's now a lot of preclinical data that tell us where not only the ACE2 receptor proteins are located, but where the virus itself actually can bind in the entire organism. All right, moving along. So, what do we know about the virus that helps us create an antiviral drug or vaccine rapidly? Well, we know the genetic sequence, of course, that was elucidated immediately. We know the receptor that it binds to, ACE2. We know what cell types it infects. So it binds to epithelium in the lungs, it binds to epithelium in the liver and the kidney and the GI tract, and it binds to type 2 pneumocytes in the lungs. And most importantly, we know that it can bind to endothelial cells in the circulatory system. These are all sites of potential damage, and they tell us, they give us hints as to how we can combat this, at least at the preclinical level. We do understand that the genome does not drift very much during multiple passages in people, and so it is genetically stable. That's a good sign, and it means that when we develop a therapeutic approach, it'll probably last. We know that there's a serine protease in the membrane of the host cell that must cleave the spike protein. We know all about the gene that codes for that, and we're developing countermeasures to that as we speak. Most of the things I'll be talking about today are being investigated in preclinical models. A few are only at the level of the cells and a cell culture, and a few are in clinical trials. All right. What accelerated approaches are being tried for antivirals? Okay, so remdesivir is the one that gets the most attention. I mentioned its mechanism of action. It's an abnormal nucleotide and inhibits RNA polymerase. We're trying HIV antiviral drugs. So far, they have not proven effective. There are a number of trials attempting to utilize them. We are testing drugs that affect ACE2 binding, like lisinopril, and other drugs that bind to ACE2 as an agonist or antagonist. And we're trying to use that approach to reduce the binding of the virus to the host cells and reduce viral infection. We're also using antiviral drugs that are effective against influenza. Those studies are early, but there have been at least one small trial, clinical trial, that showed efficacy with some combination of anti-influenza antiviral drugs. We are also using antibodies to the SARS-CoV-2 surface proteins directly, and we are creating antibodies in vitro using monoclonal antibodies. We mentioned one of the previous talks at Regeneron has an advanced product that is entering clinical trials right now, and you can use both human and murine monoclonal antibodies in cultured systems to produce antibodies to scale, and that's being tried now. And of course, we mentioned the use of convalescent plasma, which is also an antibody approach that's been used. Again, none of these have been proven effective in double-blind phase 3 clinical trials. We're also attempting to use low molecular weight drugs designed around the S protein structure, and that's progressing, but it has not reached the clinical trial stage yet. What accelerated approaches are being tried for antivirals? Okay, I mentioned we've got drugs built around the H2 receptor serine protease. I know of 2 of these, and they are designed to inactivate or inhibit protease from binding, and they're in cell culture studies. I mentioned the fact that androgens have been implicated in the severity of the disease. Very interesting new theory. We find that men are more frequently seriously affected by the virus, and more men are infected. And actually, there was a study that showed that men with the male pattern baldness are more likely to be infected and become sicker. And because of these, and we also discovered that people that are undergoing anti-androgen treatment for prostate cancer are less likely to be infected or to be seriously sick. So there are a lot of approaches now to try to reduce androgen levels in the body and thus reduce disease severity. Now, also in terms of antiviral treatment, we're really concerned about endothelial cell damage right now. There's a lot of talk about blood clots in sick people that are in the hospital in the ICU caused by the virus. We know that endothelial cells have ACE2 receptors, and we know that the endothelial cell is the site of the inflammatory response. We think that type 2 pneumocytes become infected in the alveolar cells. They lyse and they release inflammatory agents, and those agents themselves induce inflammation in the endothelia. The endothelia itself can be infected, and by being so infected, further induce inflammation. So IL-6 inhibitors and dexamethasone and other anti-inflammatory agents are being used to try to reduce the cytokine storm and general inflammation in general that's known to accompany infection with the virus. And what about for fast vaccine development? Where are we here? Well, there are a lot of attempts at using mRNA vaccines, and these have reached clinical trials. mRNA vaccines are a sort of high-tech approach to the problem. They're being tried predominantly because they are so easy to produce. All you really need is the sequence of the of the genome of the virus, and you can make an mRNA vaccine. And there are 2 or 3 of these now going into clinical trials as we speak. As I'll mention in a minute, mRNA vaccines have been shown to induce neutralizing antibodies in non-human primates, but an mRNA vaccine has never been approved for human use, and we've got about at least 10 years of trying. We have vector vaccines, vaccines that introduce the nucleic acids into host cells that then produce antigens that produce the immune response. There's adenovirus vectors, or VSV vectors, and measles vectors. We have direct antigen vaccines. This is where you produce the spike protein antigen in vitro by transfecting culture cells, and you can make a very large amount of these antigen and do it very rapidly. Sanofi, Glaxo have a partnership that are well along in the development of large amounts of these antigen vaccines. I find this very exciting, and one of the main reasons that this is important is that Glaxo's got a well-established adjuvant. Adjuvant is a protein that, or is a not a protein. It's a compound. Let's put it that way, as a class that stimulates the immune system in conjunction with an antigen. And because we feel that older people are going to be less able to mount a good immune response, or at least we're afraid of that, having a good adjuvant is going to be critical for many of these vaccines to be successful. And Glaxo has 1 billion doses of adjuvant in preparation and should be done in the next few months. And they're prepared to share it with numerous vaccine development programs. Lastly, we have on the vaccine front the oldest approach, which is to use inactivated virus. This has been taken by a number of Chinese companies, and the one that's the furthest along is a formalin, in fact, inactivated vaccine that's in phase 2, phase 3 clinical trials in China today. The advantage of inactivated viral vaccines is they're very easy to produce. There's a long history of their use, and you retain the entire surface antigenicity of the entire virus. I mentioned that we're afraid that the vaccines will not work or not work as well in the elderly. Adjuvants are a possible answer for that, and Glaxo's squalene-based adjuvant is very exciting in that regard. So, so what are we doing as a company, my company? My company takes all this information, and we are approached by many biotech companies, pharma, large pharma, small pharma, and a number of federal agencies that want to test an idea. Most of them come with data that is garnered in cell culture, and they've got to test the efficacy and safety of their drug or their vaccine on animal models. And this is not as easy a process as one would think. There are well over 100 efforts in this regard around the world, and only 12 so far that I know of anyway have gotten through the preclinical animal testing stage. So first, the academic center or a biotech or pharma company that has a potential antiviral or vaccine, they probably tested in their labs and shown some positive results in cell culture, maybe vero cells or human epithelial cells. they've got to first create enough product at the level of what's called research grade, which is highly purified, to undertake a preclinical program. The FDA does not require full GMP manufacturing rigor at this stage, so that you can, in a laboratory, produce a research grade product that they'll allow you to test in the preclinical arena. And what we're finding is that getting enough product to do preclinical testing is a big hurdle for many of these companies, especially for the mRNA vaccines. It's so easy to produce an mRNA vaccine. It's not so easy to produce enough of it to get a response in an animal model. And we have a lot of experience with gene therapy, and many of our partners in gene therapy in general are rate limited by their ability to produce a sufficient amount of the mRNA, if that's what it is, or RNAi, or whatever the gene therapy is, to actually demonstrate safety and efficacy in animal models. It's a big problem today, and it's not going away. So then the product has to be formulated so that it's stable and tolerated by the animal models, and presumably people. This is not a simple task. Everything that you put in with what's called the API, or the active agent, has got to be shown to not inactivate it and to not itself cause harm in the animal, and to keep the material stable, and to keep the material probably in solution. And the excipients, these excipients are called, can be a wide variety of things, and some of them might be toxic. Some of them might inactivate the agent or the vaccine or the antiviral. And as such, you've got to test it. You've got to test it in test tube, then you got to test it in the animals. And as I mentioned, there are a number of animal models that are now becoming sort of standard of care in the drug development for SARS-CoV-2. And then lastly, the product that you're creating has got to be created in such a way that you can get it into the patient, and do so in a rapid way that doesn't waste a lot of product or inactivate it, whether that's through injection, through an oral dosage, through inhalation, transdermal. There are many ways of getting a product into a subject, but you got to think about it from the very beginning. So first, you test your product in cell culture for efficacy. This could be as simple as showing that the SARS viral binding or entrance into cell is inhibited by the product, or that the replication is blocked in the case of remdesivir, for example. I mentioned viral cells, and a number of human lung epithelial cell lines are used for this purpose. Most of the folks that come to us have already done that part. Then the FDA is going to require proof of efficacy and safety in 2 species of animal model. This is usually a rodent and a non-human primate. We've shown that African green monkeys are the best non-human primate model for this virus. And the choice of small animal is very important as well. Initially, the University of Iowa had a group that created a transgenic mouse with the ACE2 receptor, and they gave that to Jackson Labs. And when the virus pandemic first became apparent, Jackson Labs began an expansion of those mice, and now you can buy these transgenic mice from Jackson Labs, and was initially the main small animal of choice to test vaccines and antivirals. It's kind of gone out of favor right now in that you don't produce much disease in these animals when you expose them to the virus. turns out that hamsters are a much better model for this in small animals and are now the small animal of choice, although some folks are using ferrets. Once again, the ferrets don't get very sick and they can't pass the virus from ferret to ferret very easily. After proving safety and efficacy in a small animal, you have to go to a non-human primate, and that's becoming a problem because all over the world, everybody's doing this, and we're running out of non-human primate models that have been suitably quarantined and are of the right age and type for FDA-approved preclinical investigational new drug studies. One must develop a way to introduce the virus itself in a manner that duplicates the presumed human infection process. So you can't just test your drug or your vaccine on an animal unless you can also give the animal the disease. And that means you've got to be able to show that you can give the disease in the respiratory tract, either through an aerosol inhalation or tracheal wash. And that's a tricky thing and not easily done. You have to be experienced in doing that to actually produce the disease in a way that duplicates the human condition, because ultimately you're trying to inhibit either the process of getting the disease or the progression of the disease, and you need to duplicate the human condition. You need to introduce the antiviral or the vaccine as well. As I mentioned, you've got IM, IV, oral, inhalation, transdermal, and so forth. We like the inhalation route, and one of the reasons we like it is that you're putting the drug or even a vaccine, and we've shown that vaccines work when given as an inhalation therapy as a preventative. They can induce an immune response from being introduced via the lung, believe it or not. And a key point here is that inhalation of especially an antiviral drug requires about 1/30th the dose to get the same amount of material into the lungs as it does if you give it intravenously. So we find that remdesivir is a good example. That's a drug that has 26 steps to synthesize it. It takes 6 months to make a dose of remdesivir. And so the availability of that compound is critical. It's going to be rate limiting. If we can show that it's effective through inhalation, then you only need 1/30th of the amount. Then next, you need to develop some endpoints in your animal models, something you can measure to prove that your drug, your antiviral, or your vaccine is itself not toxic and that it works. Toxicity is generally measured via the histopathology of the lung, the GI, the kidney, the liver, and or abnormal immune response from blood samples. Gross endpoints might include physical behavioral abnormalities in your animal model, eating habit changes, weight loss, fever, coughing, sneezing, etc., and of course, mortality. Efficacy can be determined by measurements of symptoms, normal histopathology, and measurements of immune response, including the mounting of neutralizing antibodies in vaccine trials. All of this has to be done in 2 species of animals, and it has to be done rapidly. As you'll see, this process normally takes about a year. Lastly, of course, in both vaccine and antiviral trials, at the preclinical level, the ultimate efficacy measurement is prevention of symptoms and or viral replication on a SARS challenge via the respiratory system. In some cases, the presence of neutralizing antibodies may be taken indicative of efficacy. So what is happening right now? So for about 12 agents, we find that the FDA has approved them, or the FDA equivalent in Europe has approved them for phase 1 clinical trials. That means that about 12 of these entities have passed preclinical testing. Now the FDA is allowing human studies to start. That's our phase 1 studies, which are clinical trials using people to test for toxicity, for safety. After the preclinical tox studies are completed or nearly complete. They're not requiring that you show that the drug actually works. They're just asking that you show that the drug is not toxic. And they're even bending the rules a little on that. We're finding in some of our cases that the FDA is allowing phase 1 studies to progress, even though the toxicity studies on non-human primates are not complete. That's a very, very accelerated approach on the part of the FDA. In some of the cases, like remdesivir, some of the HIV drugs, some of the anti-influenza drugs, of course, they've already been shown to be at least safe in humans, and they can more easily, rapidly go into clinical trials. Now, and specifically, we've got 2 or 3 mRNA vaccines. They've all passed safety trials with non-human primates. These are rather superficial trials. These are trials that would not normally pass muster with the FDA. And not enough animals have been used, but the FDA is sort of bending the rules. And so these mRNA vaccines are migrating now into clinical trials, phase 1 trials as we speak. And we have seen that the mRNA vaccines do produce neutralizing antibodies in non-human primates. As I mentioned, an mRNA vaccine has never been approved for human use today. In terms of the adenovirus vector vaccine, they've also passed non-human primate preclinical testing. I might point out that about 50% of the human population has been previously exposed to adenovirus, and many of those people mount an immune response to the vector. This could be a problem, and we don't know how serious is that going to be until we get into phase 3 clinical trials. The measles and VSV vector vaccines use a Janssen proprietary system that has a long history of safety in animal models. So they've passed preclinical testing in non-human primates and are now being directed toward phase 1 clinical trials. And we hope that, that they'll be starting here in the next month or 2. Now, when we do a full preclinical program, it's called an IND program. It normally takes about a year, costs about $1 million to $1.5 million, and involves all of the steps that I've described so far, whether it's a vaccine or antiviral or any drug. We are pushing this process with the help of the FDA and our partners so that we're doing super accelerated INDs in as little as 5 months. That's quite dramatic. I never thought I'd ever live to see that happen, but it is. The pandemic has caused everybody to sort of bend their operating procedures to speed things up. I mentioned that non-human primate availability is becoming a rate limiting factor. The FDA is bending the rules on preclinical testing to get more products into phase 1 faster. And my last statement in conclusion here is that if I look at the entire spectrum of these 100 plus approaches to combating this pandemic. It's my belief, and the belief of many preclinical researchers, that we're going to end up with a variety of approaches to combat this pandemic. Both antiviral and vaccines may be needed. More than one vaccine, almost for sure, is going to be needed. The ability to produce enough vaccine or antiviral drug is going to be rate limiting, and we're going to be mixing and matching them in our medical centers for the next year at least, maybe 2 years, to get the optimal combination that produces the best effect. And we don't know which ones are going to be the winners, but I'm going to be guessing that it's going to be more than one. We're also going to be very concerned about effectiveness of these products and the age of the population that are the subjects of the phase 3 clinical trials. It may be that you can have an antiviral or a vaccine that's very effective on a 20-year-old, but is only 30% effective in somebody over 65. And you're going to have to add adjuvants. You're going to maybe have to have a second a vaccine given to people that are older. You may have to give booster shots that go into 2 or 3 or 4 doses to get the same immunity. We don't know the answers to any of these questions. They're going to be worked out through trial and error. And interestingly, one of the main rate limiting factors we're going to find is finding enough patients to actually test efficacy in phase 3 clinical trials. You need tens of thousands of subjects in such trials, and you're not going to find them in many of the places where we initially had the outbreak. We're finding that many of our partners are going to Brazil or other third world countries where they have a rapid increase in infectivity, and you can get the subject number that you need. So it's a complex problem, and it's probably going to be solved by complex solutions. This is my talk. I'm sorry I had to go so fast, and I thank you.
Thank you very much, Dr. Rubin, for this interesting presentation. What's in the mouth of everybody is what's your prediction, and when will we have a vaccine available for the American population, as the first question? And the second question is, in any viral epidemic, and not even a pandemic, but just like the flu epidemic that we see, the seasonal flu, every year we're coming with new strain that are different, and as such, there's an additional layer and challenge that people to produce the vaccine that requires to develop a vaccination directed against a new strain. Do you foresee that all this effort that we're doing right now for a vaccine will need to be readdressed as we move forward to the next season?
Fair enough. I'll take your second question first. Looking at the genetic drift of the virus, my guess is that a vaccine that's effective will be effective for many years. It's not like the flu virus. Coronavirus in general are very stable. My company was a lead company in the production of the SARS-CoV-1 vaccine funded by the NIH. And to the best of my knowledge, most of the virologists that have studied coronaviruses in general believe that a vaccine will be good for many years. So that we think we're lucky in that regard. And your first question is, when will we see a vaccine that the average person in the United States could take? My guess is, if everything goes perfectly, and it almost never does, it'll be about a year. We're going to be entering into phase 3 clinical trials with a number of these approaches starting in the first of the year 2021. And the phase 3 trials take many months. There are a couple of the vaccines are already beginning phase 3 or will in a month or 2 or 3. And the FDA may break into their data and see some efficacy and tell them to go forward right away. I think 3 or 4 of the big pharma that are developing these vaccines are already gearing up to produce tens of millions of doses now, even without proof of efficacy or even proof of safety, so that they could be ahead of the curve and have vaccine at scale by the end of the first quarter of next year. But just having vaccine at scale, assume all of that works, doesn't get a dose to you. It's got to be approved by the FDA. It's got to be produced and then packaged, and then it's got to be sent out to all of the probably the departments of public health of all the states, and then they could distribute them directly to doctors' offices and to pharmacies. And that's not an easy task at all. And the way that the vaccines will be administered has to be worked out. People have to be trained. And then you have to have enough people willing to actually go get vaccinated to make a difference. So I would be astounded if we're not at the very best at least a year away from that situation, and quite possibly 2.
So the future, the way I summarize it, it will be a year from today to have the vaccine, which is this almost the beginning of the summer 2021.
Yes, yes.
Short of that, and to live in a positive note, I should say, short of that, what would be your best bet in regard to a therapeutic compound that will be good enough not to prevent, but to treat and avoid complications such as the one that we saw?
All right, fair. So that's a good question. I think we're halfway there. I think the data on remdesivir and dexamethasone is so startling, so positive in its initial trials, that as the physicians become better at administering these compounds, and they figure the earlier times to administer them, as the testing gets better and we identify people who are positive and just beginning to get sick, and we start treating them earlier, I think you're going to find that the mortality goes down and that the hospitalizations goes down. And I think we're going to, I hope we're going to see shorter than a year antibody therapeutics come to their own. And so now you'll have 3 approaches to treating people who are testing positive. And with those 3, I think you're gonna have a possibility of a dramatically improved treatment paradigm. It won't stop the pandemic. It won't stop probably having much effect on the rate of infection, but it'll dramatically reduce the pressure on the hospitals and on the healthcare delivery system, and a lot of the fear factor will be reduced. You worry a little bit that the public, if they begin to see that we're beginning to treat these this pandemic much more successfully in the hospital, might get sloppy, which is actually what happened with HIV when we saw the continuing decline in infection slow and actually stop when we had effective therapeutic interventions for HIV. So you worry a little bit about what the public's behavior is going to be. We're seeing right now, I think, a behavioral-induced spike in transmission as states open up their businesses, and I think you would probably see that increase if we actually had effective treatment, especially early on in the course of the infection.
Thank you very much, Dr. Rubin. And on behalf of New York Medical College, this concludes this webinar. I'd like to thank all the panelists for this very insightful webinar with the state-of-the-art presentation, cutting-edge research, cutting-edge information. The field is in movement, and we look forward to hearing from you all in a very near future. Meantime, the only thing that I can suggest is PPE, wash your hands, protect yourself, distancing, and put that mask, even at the expense of not seeing the smile. Thank you very much. Have a wonderful day and stay safe.